So what are my conclusions? I think sepsis is a severe issue in society today. It's getting worse. I think it's very treatable. In other words, if we do a good job versus if we sort of just do a so-so job, it's a huge difference in outcomes that we can make. I think our ability to clinically diagnose sepsis is very limited right now, and the data says it's not getting better, so low in the 70% range. So I think we need to be thinking about biomarkers. In 2010, I think procalcitonin is the best biomarker that's available. It's not necessarily the only biomarker, but if you look at what we could utilize today at the bedside, I think it's the forerunner. I think we do need to develop protocols on how we're going to respond to these things. In other words, again, it has to be tied to a therapy change. If you just draw the level and don't do anything about it, it's not going to change your therapy. And then following procalcitonin, the typical ICU patient can identify and give you an early trigger of an infectious process that may not have clinically presented as of yet. I think that's my last slide, so I'll be happy to answer some questions now or any comments.
Thank you very much again. On behalf of the Merier, we appreciate your insights and time today. I'd like to answer some of the questions. Doctor, would you recommend starting antibiotics on someone with high PCT but no other evidence of infection?
Well, I'll tell you what I talked to our residents about. I mean, again, procalcitonin is not supposed to be looked at in a vacuum. So number one, if you get an elevated level that you weren't really clinically expecting, I think number one is you need to go back and re-examine your patient. If it's real, and of course we always worry about false lab that was drawn from the patient next door and lab error. But if it's real, in general, I mean, it implies there's something going on, and usually it's something that we've missed. So I'll go back and re-examine that patient. I think endocarditis is one of the common things that we often see in patients that, they often have clear chest x-rays, and we don't see an obvious source of infection. So, yes, I would on a patient, especially if they're unstable, then for sure I'm going to start antibiotics. If they're relatively stable and the procalcitonins are not very elevated and kind of in that 1 to 2 range, I may continue to reculture and watch. But if I get a significantly elevated level, we're talking above 2 to 4, I think the test is that good that I would go ahead and culture them up and start antibiotics and reevaluate over the next 2 or 3 days.
Just a quick follow-on to that question. You talked about PCT releasing the absence of infection in one of your last slides, and there are some who believe PCT is really the main mediator for sepsis. Have you ever seen that, high PCT that without an infection that led to sepsis?
No, I haven't seen that high procalcitonin level that caused infection later on. People have always talked about, what is the benefit of procalcitonin, teleologically, et cetera. Why should we have these elevated procalcitonin levels? Is it a helpful molecule? Is it a harmful molecule? And I don't think the data is out there exactly yet. There's some data that talks about maybe we need to be giving these septic patients procalcitonin in some fashion. It improves outcome, i.e. teleologically this was an immune defense mechanism. And others believe that, no, we actually need to be making an antibody to procalcitonin and get rid of it because it's harmful to the patients. So I have not seen it actually cause infection in anybody, though.
Okay. Dr. Oltermann, when your institution was evaluating PCT, what were some of the barriers that you had to overcome before making the decision to implement the test?
Well, of course, everybody talks about, number one, the cost. Is it a costly test? What's it going to replace? If I do this test, what can I get rid of? So it was a little bit of a struggle. The other issue is that we in the intensive care unit were the ones that were really pushing for it because, again, I had been following C-reactive protein for a number of years and, again, got frustrated with too many false positives. You have C-reactive protein elevates also with just inflammation, irrespective of whether the patient has infection. And so we often felt like we were over-treating patients. So based on my review of the literature, I felt procalcitonin would be a better marker to be looking at. What I didn't do, and it wasn't until later on, that I really started looking at the emergency room. So number one is I would try to, if I had to do it over again, I would try to get your small subcommittee together of intensive care unit and emergency room people together, physicians and non-physicians, and I'd get your lab persons actively involved and go over the data and try to make some recommendations on how this can actually alter care and improve outcome. I think the data, there's a lot of good data out there now that procalcitonin is a very good test in helping you make decisions about antibiotics and making decisions about the severity of infection.
Okay, our next question here. Can you expand on your thoughts for using PCT for the detection of sepsis in the critically ill burn patient?
I don't do burns anymore, so I've not seen specific procalcitonin literature in the burns. So if I was doing that today, what I would do is I'd just start collecting my own data on all the burn patients and try to make some sense Again, I would expect, especially early on in a burn, just very similar to the trauma patient, that procalcitonin levels would be elevated for the first few days, but then in the absence of new infection, that the level would drop. But I've not seen any data at all in burn patients. I think it's an active area of research. There's so much that we potentially can do with procalcitonin, and again, it's so far ahead. It may not be the perfect biomarker, but I think there's so much that it's so much easily accessible right now. There's a lot of new questions that need to be answered, and procalcitonin, I think, is a place to start.
Okay. Does your hospital have set protocol for sepsis, and is PCT part of that protocol?
We've got a new ER director right now, and we're about to redo our whole sepsis protocol. It is, on the patients that are coming to the intensive care unit, procalcitonin is a standard for a lab to be drawn, essentially on all the patients. So what I'm trying to do, though, again, since we started using procalcitonin primarily as an ICU, not necessarily ER, I think the ER was a little bit behind. So right now we've got to get together, improve our protocol of getting procalcitonin levels drawn very early on these patients. You know, it's kind of interesting. Our hospital got a grant a few years back to draw HIV tests on everybody who walks through the door. If they're getting any blood drawn at all, they're all getting HIV tests. And occasionally you'll pick up somebody that didn't know they had HIV. But, I mean, I think, boy, if we could get a grant for procalcitonin on every patient who's getting blood drawn, I think it'd be a much more helpful test. So anyway, we're revamping our sepsis protocol that will include a procalcitonin level, and I think that we got to get them drawn early, and we got to get the physicians to utilize them in their decision making.
Okay. One individual asked about your affiliation again, and I'll just repeat that. Dr. Mark Oltermann, MD, is with the John Peter Smith Hospital in Fort Worth, Texas. I'll go to another question here, a clinical question. Do you routinely order PCT on patients presenting to the ED with diabetic ketoacidosis?
I do when I talk to the residents about patients with DKA, because I think, again, we're always looking. Now, it's true that their incidence is relatively low. If you look at all DKA patients, you know, maybe 10% or less are actually going to have infection. But it's so easy to miss because they already have all the SIRS criteria, and, you know, they all have, almost all of them have elevated white counts because they're so hypovolemic and dehydrated. And occasionally is when you get burned. So we had a lady, for instance, that would routinely come in, you know, a couple of times a month with DKA, a young woman. Her IV access was so bad that she had to get an implantable port put in because she had no more veins anymore. And she comes in, and the residents admitted the patient. They drew their procalcitonin. Procalcitonin level was 15, but nobody did anything about it. Nobody cultured her up at that time, put her on antibiotics. And it wasn't until a day later, 24 hours later, that she actually had a documented fever. Turned out she had line sepsis with her catheter. So that was a major, I think, a major miss. So anyway, it's not that common, but it's such a good test that it quickly sort of rules in and rules out whether they have major ongoing infection as a trigger for their DKA.
You talked about Xigris treatment and the cost of that treatment. Is there any correlation, even anecdotal, between PCT levels and when to use Xigris, or when you get the optimal benefit from Xigris?
No, I don't think I haven't seen any data on that. But again, if you look at the Xigris protocol that's put out by the FDA, it's supposed to be those with, quote, high risk of death. And of course, the way they defined it in the trial, and then subsequently there, you know, as an example of an Apache score greater than or equal to 24. Well, you know, it takes 24 hours if you're doing Apache scores. You're really supposed to do it in the whole first 24 hours. Apache scores are notoriously hard to get everybody to do. So if you have a simple test that would correlate with, quote, high risk of death, I think it could be a good screening tool or potentially a good trigger. So again, I think it's going to be interesting when the Eritrean trial comes out, the Access trial comes in print, and see how procalcitonin fit in with their scheme.
Okay, last question submitted here is, do you utilize PCT to help decide whether to admit a patient to the ICU versus wards?
You know, I'll tell you, just we don't have a protocol, and so there's no protocol that says, well, your PCT is above X, you got to go to the ICU. But when we go out we get asked to go see a patient, say out there on the wards, and they're having some trouble, and we're trying to decide, are we going to transfer this patient to the ICU or not? I mean, the first thing I do is draw a procalcitonin level on those patients, as well as some of the other biomarkers, to try to help me make that decision. And so clinically, I do that, but I don't have a protocol for that, because I know that if their procalcitonin levels are majorly increased, that their risk of doing poorly is worse, and it's a lot easier to bring them in early and get them dealt with, as opposed to have them sort of get worse and crump on the floor.
Okay, I think with that, we're going to wrap up. We'd like to thank you for your participation today. I'd also like to thank our sponsor, bioMérieux, for facilitating this valuable scientific exchange. Of course, we want to thank Dr. Oltermann for a great presentation. It's been our pleasure to bring together Dr. Oltermann and several other experts over the past 18 months on this series of webinars. Thanks again, Dr. Oltermann, and everyone.
Thank you.
With that, have a good day.